topic that we are going to be having right now is a very important aspect of patient safety. But let us first look at what we are seeing here, right? I'm going to paint a small scenario for you, and let's see from where we can take you there. Scenario first. On the 3rd of May, Nikita Manchanda, who's 30 years old, gives birth to a baby boy. And on the 4th of May, at about at 10 p.m. or so, she complains of abdominal pain and back pain. The nurse then subsequently rings up the doctor, who then prescribes a painkiller. Right? The medicine is then administered. I repeat that the doctor has spoken to over the phone to the nurse, and that's how the drugs are given. Now on the 4th of May again at 11 p.m. There has been no improvement in Nikita's condition. The nurse again calls up the doctor, who again prescribes some more painkillers. Now what happens is, on the 5th of May, her condition deteriorates further. And then finally the nurse informs Dr. Pooja, who is on night duty. Dr. Pooja comes, but leaves after a cursory checkup. On the 5th of May again, this is at 6 a.m. in the morning. After a fair amount of pain throughout the night, Nikita starts to vomit. Dr. Pooja arrives, but isn't able to diagnose the problem. Nikita's condition worsens. Her blood pressure dips. On the 5th of May at 7:45 a.m. the senior doctor comes and finally checks on Nikita and advises that Nikita be shifted to the ICU. On the 5th of May at 8:30 a.m. Nikita finally shifted to ICU, but she sings, starts gasping, her pupils start dilating, and she stops responding. The skin goes cold and she finally collapses. And at 9:30 a.m. she is put on ventilator. At 10 a.m. she is declared dead. Right? Now this is the broad scenario. Who do you think was at fault? This had a lot of wide publicity in the newspapers and other media, print media, but who do you think was at fault? We can discuss probably at the end of all the slides, since I'm sure you can sit and listen to that from there. Now thereafter, Nikita's family filed a complaint of medical negligence. The family members are also alleged that hospital didn't have a blood bank, and that the patient's family was asked to go to another hospital which is about 10 kilometers from there to get blood for the patient, and also that the 9th floor building had only 2 lifts, one of which was stopping only at selected floors. There were multiple problems that they were complaining about. Now the average waiting time for the lift is 10 to 15 minutes is what they were saying, and plus also that Nikita was on the 4th floor, whereas the newborn baby was on the 2nd floor, and feeding was difficult and became more and more painful as the pain progressed. Now that is one scenario. Do you think it is medical negligence? Think about it. This is another huge news that came in the Indian media about 7 babies who died in a span of 1.5 days in a hospital in Malda, right, which is a city in West Bengal, which is a state in India. There is another place in one of our states in the country where the death happened, right? So I hope I can hear. I don't know if you can hear me at all. So this is another incident. Many such deaths have been reported that happened there. Now this is the second scenario. This is the voice of a man who is telling us a story of his father in his bed. He was saying this is what he said. He was saying he was trying to rise, but his muscles were so weak that he couldn't sit up anymore. I was only 13 at that time. He has been in the hospital for 2 years, but still kept on losing weight. The doctors could not find the correct diagnosis. He weighed 195 pounds when he was admitted, and today he's only 70 pounds. He was extensively checked for all kinds of cancers and referred to psychiatric counseling. His business had suffered huge losses, and he went home expecting to die. She says that his mom started to read stuff on her own, and that she finally found about gluten absorption. I think you must know gluten absorption problem. For example, cabbage and things like that have gluten in them, and later was made the diagnosis of celiac disease. But the question that he repeatedly asks the healthcare workers is as to how could 2 years of testing overlook what my mom could find in a span of a few months. That is the question that he wants us to answer. My father has permanent neurological deficits secondary to severe malnutrition. And why wasn't parental nutrition maintained? He says that his family is now financially insolvent. What was all the money we paid used for? Very, very important questions that can be asked by and to all of us. The question that I want to ask you is, are these instances of medical negligence, or are they a problem which is a larger error in the system? That is the question. A very important point which I want to make here is this, is not who caused the accident, but what caused the accident is what is relevant. And I quote Lucien Leap, a famous physician who's worked in the field of patient safety, where he says that medical errors most often result from a complex interplay of multiple factors. Only rarely are they due to the carelessness or misconduct of a single individual. Very important, very relevant. Now let us move towards what is I'm going to be dealing with one aspect of patient safety. Patient safety is something we all have heard, so I didn't want to give an all-encompassing lecture on patient safety. I wanted to take up a specific topic of patient safety and speak about it. What is patient safety? Patient safety is the freedom from unintended harm due to healthcare intervention. Patient safety is actually a healthcare discipline that emphasizes the reporting, analysis and prevention of medical errors that often lead to adverse health events. And what are these commonest errors that are held, which are the improper transfusions, you have wrong side falls, medication errors, restraint related problems, burns, misdiagnosis, problematic identities. These are the commonest errors that happen. And what are the commonest areas? Obviously the places of the hospital that are most crowded, the busiest, the high strung areas, that is the ICU, the OTs and the emergency rooms. These are the most busy areas of the hospital, and the problem really is that majority of the care today is actually being given in the outpatient and ambulatory settings, which themselves can pose specific problems. Now, why is it so difficult to perceive harm caused in the hospitals? Every time we have a plane crash, it's all over the place. With all due respect to people who have died in the in the Malaysian Airlines, why does it make such a big news? It's because it's obvious and you can see it happening, whereas errors in patient safety are happening so subliminally, so subterranean level that you don't get to know what is happening. Now, real harm is much more impressive if there is financial implications involved, if there is resource utilization that happens, if you end up spending more money, if you end up using more resources to overcome that problem, that is where you have real harm is appreciated more. But for example, as the slide shows, we have when there's $29 billion are lost in income, disability, or healthcare cost, you appreciate that. But how do you appreciate experience of patient who harm, the experience of a patient cannot really be evaluated, how badly he felt about something. Or for example, the fear and the lack of trust and the lack of faith that comes up when a patient has once already been affected by the illness, that cannot be measured, but which really is a very important factor. The other one is the physical and the psychological harm that has caused. Sometimes patient are so traumatized that they really can't overcome it. Finally, the doctor who has caused it, the loss of confidence that he suffers is really enormous. So, and that would affect his career for the rest of his life, and the harm that is caused to that is enormous, right? Now, this is a very important slide because it says that the WHO has said that 1 in 10 persons who receive any kind of a care or treatment suffers from preventable harm. That is a reality, right? Now here's a fact file. It says that 1.4 million people worldwide, patients worldwide, suffer from healthcare associated infections, and 50% of all medical equipment are either unusable or cannot be effectively used. 70% of sterilized or unsterilized syringes, 70% of all syringes which are used are unsterile, reusable syringes, and that is really a huge number, really, when you talk about in terms of millions of use. 1.3 million injections which are given every year can cause death. Now, briefly, I want to tell you about where it all started. It started in 1999 by a huge, fantastic report called the To Err is Human, which was given by Institute of Medicine, and it came out of this 3,000-page report. It's an amazingly lucid and well-written report, and available in many languages, and you can download that freely from the net. And it's an amazing. It was, when it came out, it was quite a bombshell dropped on the world, where they realized that one of the biggest issues is medical error. Right now, thereafter the WHO started what is called the WHO Global Patient Safety Challenge, GPSC. Which is, the first was an enormously successful challenge called, the first was an enormously successful program called the Clean Care is Safe Care. That was a very useful program. Second was called Safe Surgery Saves Lives. The third one was called the Tackling Antimicrobial Resistance. All three of them, there's a lot of stuff to be spoken about, read about here. I'm not going to be talking a lot about that. I'm going to specifically restrict myself to one but very important and often overlooked point, which is called the medication management. Now, medication management, I hope some of you have heard it. It's very relevant to doctors, to nurses, to paramedical staff, and so on and so forth. What is medication management? And I'm going to quote the NCCMERP, which is a National Coordinated Council for Medication Error Reporting and Prevention, which defines medication error as any preventable event that may cause or lead to inappropriate medication use or patient harm when the medication is in the control of the healthcare professional, patient, or his attendant or consumer. Right? Understand this. There are certain terms which are important here. One is preventable event, right? And something which can cause patient harm or inappropriate medication use when it is in the hands of anybody, a doctor, to in the hands of the healthcare worker, and now the patient as well, right? Now, this can be as a result of professional use, because of procedures, products, systems, prescribing, communication, labeling, packaging, compounding, administration, so on and so forth. So this can be because of any of the above reasons. Now, broadly, medication errors can be because of the following reasons. It could be prescribing error, right? That is, what is prescription? I'm sure you know what prescription are. You assess the need for and you select the particular drug. You individualize the therapeutic regimen according to the patient and give the patient the drug. That's called or writing that drug is called prescribing. Dispensing, administration, monitoring, and system and management control. These are the various medication processes. Now, medication error can really be broadly classified into prescription errors, transcription errors, dispensing errors, administration errors, and monitoring errors. So you have prescription, transcription, you prescribe, you transcribe, you dispense, administer, and monitor. Any of these 5 stages can result in a medication error. This particular slide, I want you to focus on that slide, and it speaks about at an average about the largest percentage is caused because of prescription, wrong prescription, followed by wrong administration, followed by transcription, and finally by dispensing. About 2 lakh odd medication errors happen every year, but not all of them are harmful. Less than about 1% is harmful, and about 1.1% of that is causes about patient death. So that's about out of about 2 lakh or so, 36 odd cause death among patients. That's a pretty big number if you analyze. Again, focusing on the types of medication errors that we have. We have prescription, transcription, administration, and dispensing and monitoring. You can have wrong dose, wrong choice, wrong drug, wrong route, wrong known allergies, missed dose, wrong timing, wrong frequency, wrong technique. Commonest is wrong dose. That's 28% of all errors happen in terms of wrong dose. You can have drug-drug interaction, wrong route, extra dose, failure to act on a test. You give a test and then something goes wrong, you don't act on it. You give a wrong drug, that's called the wrong choice, or you give a wrong choice of drugs. You have a known allergy, you still give the drug, that's still an error. You have missed a dose, even that is an error, right? You don't monitor adequately, that's an error again. And finally, other causes. So these are some of the errors that can happen. Now, quickly moving on to I'm aware that some of you must have known what medication errors are, and these are the principles and strategies for medication management. What are the strategies? One is selective strategy to improve medication safety are you must adopt all patient safety errors are primarily a system defect. The error lies not in the drug itself or a particular person or the way they handle the drugs or the hospital. The error lies in the system, right? So one is that we have to adopt a system-oriented approach to medication error reduction. Second is that we have to implement standardization of I'm sorry about I'm spoonering. We have to implement standardization of dose timing, of medication dose, how you're going to give it, how you're going to scale it, how you're going to customize it for every patient. Third is that we have to standardize the prescription writing and prescription rules. How are you going to prescribe the drugs? How will you ensure that it is being written in the right dosage? We have to limit the number of different kind of common equipment. For example, what really happens is that the ICU, you have X number of infusion pumps. So you have to ensure that you use the same company infusion pumps, so that everybody is familiar with the same way it works. For example, just like we used to particular laptop a particular way our system functions. Similarly, we have to ensure that the number of different kinds of common equipment have to be kept the lowest. Many Western countries have a computerized physician order entry system, wherein you have the physician kind of giving the prescription on the system. The system pops up with whatever is wrong with what you prescribed. It also gives prompters, so that kind of ensures that your errors are rectified at each level. That and by the use of pharmaceutical softwares, we also have unit dosing system, and we have and more importantly really is that we need to make sure that the pharmacy is being centrally monitored. We ought to have a centralized pharmacy within the hospitals where this thing is implemented. Right, we have to have a special and a different protocol for any of the high-risk medication that we're using. So that is one of the most important things. Certain other things, like first we should not use corrosive stuff in the wards. You must ensure that different label stuff. I'll come to that subsequently. Of course, we have to ensure that we include the patient in the decision-making process. Most important thing is for the patient to know as to what he's getting and what are the side effects, when he should take. So the patient is involved in his own. After all, it's his life and his health which is at stake, and a patient is most likely to remember his drugs better. That's an important, interesting photograph. LASA, I hope you've heard of the term LASA drugs. It's look-alike and sound-alike drugs. As you can see in the drawing, you have the gabapentin tablets and gemfibrozil tablets. Both of them look very, very similar. Looks like this is what your doctor prescribed, and this is what you got. This could happen very, very often. As I say, LASA it's a huge problem because there are thousands of drugs in the market, and there's a big potentiality for confusion among these drugs themselves. Now, what is contributing to this fact is, of course, the illegible handwriting of doctors, which is very, very famous, which is again compounded by people who having been prescribed. The pharmacy people don't know the drugs appropriately. There are many newly available products. The tendency for similar packaging. Also, many drugs have a similar clinical usage, similar bioavailability, similar action, right? And the dosage is similar or frequency is similar. And sometimes the manufacturer himself does not give adequate information, and completely so. This is an example. In even an advanced country like USA, there are 33,000 trademarked and more than 8,000 odd non-proprietary medication. So that's a number. In fact, Institute of Safe Medication Practices has given about 8-page listed items wherein you have pairs of drugs which can be confused, which look alike and sound like similar. This is just one of the pages from that inventory, and this is how it looks. So for example, Avanza is mirtazapine, and Avatita is another drug which is very similar in the way it sounds, but which is really rosaclitazone. Thank you for the water. All right. In Brazil, similar sounding drugs. I'm not going into too much of detail, but Lasix and Losec and many similar sounding drugs are often a problem. Take a look at this. I don't know if it's there in your country. Many of our smaller hospitals in India, we often have several similar looking ampules which are administered in a similar fashion. Right? Am I running out of time? No, I'm not. This is how it generally looks like. Many similar looking ampules being delivering similar kind looking drugs, but completely different in action. This is how it looks like in many of our hospitals. All the tablets look similar. They're given in similar looking small sort of boxes, and the liability for getting, or the chances of it getting confused is very, very high. Now, another problem of long doses, for example, this they wrote 50 milligrams, cut that and made it 25 milligrams, and look at the confusion that it can cause. Very often done mistake. It's a huge mistake that we do here. We cut and chop down the strips into very, very small tablets for convenience, but we can't read the drug nor the dosage, and that is often a cause for a problem. Look at this. Look at how we can have small solutions to big problems. Now here, all of them can look confusing. The same drug, they're all different dosage. How do you make dosage stand out? Very simple. You can make them stand out by ensuring that the one that is bigger one pops out, right? You can make this the 5 milligram on one side, or make a different color, or 10 milligram look differently, have a different color as well. Now here are some of the specific strategies for taking care of loss of drug. Then we come to the last bit of my presentation. Now, what are the specific strategies? You have to ensure that healthcare organizations are actively managing and actively identifying the Lassa drugs. You have to have an annual review of Lassa medication. We must implement clinical protocols which minimize the use. We must keep on having systems where you have minimal use of telephonic conversations. You have to ensure that give a drug's name and you repeat it back to you. So that is called a repeat back phenomenon. We also have to ensure that verbal orders are minimized, everything written down. You have to ensure that every time you give the medication, prescribe the medication, and you have to read the label again before you administer the drug, rather than simply relying on kind of seeing where it is kept or reading it from far. Very important. And also people who, for example, the nurse who is injecting the medication should also have a fair amount of knowledge of the condition, should really know whether the condition actually warrants this medication or not, right? So that is another very important factor which is often played out. We must also include both proprietary and non-proprietary name in the list, in the prescription itself, and should try and put the non-proprietary name much bigger so that we kind of focus more on the non-proprietary name as well. We must bring in strategies to bring down the confusions and contradictions in terms of the drugs. For example, something called tall man lettering. For example, if you have dopamine, dobutamine, both of them have common the word D, but the word P and B are different. So you can write D small a large P dopamine, right? And if you want a dobutamine, you write D small o capital B. That's called the tall man. So that way you know that this is dopamine and that is dobutamine. So that is one way to ensure that you have identified the right drug. Storing. Now we have to ensure that those drugs that look and sound alike are stored in different areas of the store, right? There is either they can be in non-alphabetical order, by bin size, or organ specific, or disease specific, and so on and so forth, and we give them the automated devices. You can use, there are innumerable techniques in the market, on the net. You can use color coded differentiation, bold face, many things can be done. You can have separate shelves and so on and so forth. Now like I said before, it's much more important This is important, but what is also equally important, and if not more important, is to involve the patients and their caregivers in reducing the risk. That's how we must do it, because you have to give the caregivers and the patient written information, written name of the drug and the information. When do you take the medication, how should you take the medication, how often, what is the drug, what are the side effects, and so on and so forth. You must, for example, in India there are like about 700 languages, so 30 official languages. So we must develop strategies to incorporate patients with sight impairment, language problems, limited knowledge. Education is, I'm sure, as in your countries as well, education is a problem. So we must know that patients often don't know much about the medicines, right? We must ensure also that the patient has the patient review cache is given to the pharmacist as well, so that the pharmacist kind of can correlate between the patient's condition and the drug itself, right? So that these are some of the simpler techniques to do it. Now, where do these problems? Why, despite so many techniques we known, despite having known that this is extremely useful, why do we have problem? We have problem because there is a huge market out there which make tons of money by selling proprietary drugs. We know that, we are all aware of this fact. There is also a personal preference among doctors. Certain doctors think certain drugs are more effective. They know it, they will continue to prescribe those drugs. There is a need. The problem is that it requires a behavioral change, and that will require a complex education campaign. We still haven't nailed it as yet as to what exactly is required. We have to ensure that a complex program is in place to inform the patients and his practitioners, and of course there is there's some amount of cost. For example, this computerized patient prescription system requires fair amount of monetary input, and so therefore technology is often not available in poorer countries. That's one of the problems. Also, there is no standardization in terms of among various countries. There are no regulations. For example, America is far more regularized system than what we have. So there is a wide variability among countries in terms of standardization or regularization of medication, and there is a language barrier which is always there, both abroad and in India, and I'm sure in your countries. The lack of technology, the lack of commitment to implement these things, and of course there is a huge industry, like a huge industry out there trying to expand the number of drugs that are out in the market. There is again no standard method for what I called earlier dopamine and dopamine example of tall boy lettering, right? And there has to be systematic use of non-proprietary names, which is not happening. And again, market pressure is always there, and there is reluctance amongst the healthcare personnel themselves to encourage use of non-proprietary drugs. With that, I would like to complete my lecture, and I'm most open to any discussions that you want to have.